Good morning. Welcome to one of the last 2 days of CCRN review. And today it's all things shock. Really happy that you're here. And I'm going to go ahead and share my screen. Okay. All right, very good. So this is our CCRN review talking about shock and the shocking truth and really simple solutions with super success. And our goal today will be really, how do we actually differentiate different types of shock, and how do we identify what's happening for our patients, and what are we going to advise for therapeutic intervention? So, of course, 2 hours is a relatively short period of time, but I really do feel that we're going to get a fair amount of information from this. I'm so sorry because this week has been a little bit crazy for me, but I will send the shock handout and the copy of my slides out today. I will ask Beth to give me hers. I will ask Kathy Peavy to give me hers, and I will also request for her to make the recording of her talk from last week. I don't think that she has that yet. All right, so very good. You know how to reach me, and always feel free to reach out to me. CCRNK, if you notice, I have a CCRNK. I made a mistake because I said, give me the K, which means that I'm not at the bedside, except that I am at the bedside. So next time you see that, after my next certification, I'll be back to CCRN. But right now, CCRNK is for somebody who is CCRN, passes the exam, passes frequently, but perhaps doesn't have enough clinical hours to maintain their CCRN. So anybody who is mostly educating should be a CCRNK rather than an actual CCRN. Okay. So really, 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 really important for us to appreciate and understand that when we're talking about shock, that shock is not defined by hypotension. Shock is defined by an imbalance of the delivery of oxygen and the demand for oxygen. So cells demand and cardiac output, hemoglobin, and saturation deliver. Cells demand, cardiac output, hemoglobin, and saturation deliver. And that means it's really important to be paying attention to your arterial sat. It's really important to pay attention to your hemoglobin, but it's most important to be paying attention to your cardiac output or your stroke volume. So what is incredibly important to remember is that tissue hypoperfusion is the underpinning of all shock. And however you measure tissue hypoperfusion, so there's many ways that we measure that. We look at the base deficit, we look at bicarb, we look at anion gap, we look at lactic acidosis, and we look at SVO2 or SCVO2. Those are all going to be indicators and measurements that tell us about tissue hypoperfusion. There's more than that, but for our exam, those are going to be the things that we're focused on. So we've talked a lot about those measures. We talked about them with blood gas. Haven't really talked that much about SVO2. We're going to do some more of that today because that's going to be a really important component. And in most of your shock questions on your CCRN or PCCN exam, there will be a SVO2 that appears, either an SCVO2 or an SVO2. So always remember that this is about whether or not the delivery of oxygen, delivery is cardiac output number 1, hemoglobin number 2, arterial sat number 3. Delivery is adequate or not adequate for the consumption of oxygen at the cellular level. If delivery is not adequate, it might be that your patient has a cardiac output of 5 or 6 or 8, meeting normal criteria for cardiac output, but it's not adequate for the delivery of oxygen because the patient's still hypoperfused. You have to pay attention to that. So by definition and by exam definition, normal cardiac output is 4 to 8. Normal cardiac index is 2.5 to 4. But a normal cardiac output is one that answers the cellular demand for oxygen. So not only are you looking at cardiac output and stroke volume numbers, you're actually evaluating whether or not the tissues are adequately perfused. So that's going to be incredibly and profoundly important when we're evaluating our patients. And we know that when you have circulatory shock, your number one focus is to restore perfusion. You restore perfusion by administration of volume, by administration of inotrope, and by enhancing vascular tone. So volume, inotrope, vasopressors. Now you also have to treat the cause of shock, right? If you're infected, you need to go on antibiotics. You might need something to be cut off. You might need to go to surgery and be cut into and have something removed. If you have heart failure, we have to treat your heart failure. But the mainstay of shock is to return circulation. Whatever the cause of the shock is, the mainstay is to return circulation. Okay, everybody good with that? That makes perfect sense, right? So we're going to start off with a little case study. It's a 47-year-old man. This is actually a patient that came into the ED when I was working basically PRN at Southern Regional Medical Center, and I was always assigned to the critical care room. So this is an 18-year-old, 20-year-old case study, and it's so incredibly valuable. Because this is a guy who's an attorney. On the weekend, he's gardening. He cuts his thumb, right? Cuts his thumb open. He's fertilizing his flower beds, et cetera, and he continues just working. He doesn't really clean it out. He doesn't put a Band-Aid or any kind of protection against it. But the next morning, he wakes up and his thumb is really sore, and the skin around the cut is really red and kind of inflamed and hot. He's got to go to work. So it's Monday. He's got a very important day. He's got to prepare all these briefs. So he puts a Band-Aid on, he proceeds to his job. But by the time he gets back home that evening, now his thumb is swollen, throbbing, and he's having yellowish white pus coming out of the injured area. And he's saying to his wife, "This is really killing me. This is really hurting me." And she urges him to soak it in some salt water. But after he does that, and it really is coincidental with his thumb soak, he becomes lightheaded. And he's like, "I'm going to pass out." And his wife's like, "Come on." And he said, "No, really, my heart is beating really fast. I think I'm going to pass out." So they call EMS. EMS comes 15 minutes later. This is what they see. Temperature is 39.7, heart rate 125, respiratory rate 24. Right away, you're concerned. He's got a temperature, he's tachycardic, and he's tachypneic, which always indicates that, no, it's not always indicates sepsis. It always indicates that you have a process. And that process typically is that there's an imbalance in oxygen supply and oxygen demand, which is why he's breathing fast. Don't jump to a diagnosis, because if you do that, you're going to say it's this kind of shock or that kind of shock, and you're tunneled. He is compensating, and your assumption is it's compensation for metabolic acidosis until proven otherwise. Tachycardia and tachypnea mean that. Now, adding in that temperature and the context of the story, Mallory, you're absolutely right. You are going to say, I think what's causing this is sepsis. But that heart rate and respiratory rate are telling you about a compensatory mechanism that is in regard to metabolic acidosis. And now you're in the pursuit of what the causative agent is. Now you've got his history. It's written down here for you. But you might not have had that when you first saw him. Yeah. So again, you don't want to jump to a conclusion, because that puts you on a trajectory with tunnel vision that then actually may interfere with other evaluations. Good? Okay. So blood pressure 100/60. His wife says normal pressure is 145/85. So he's down. His blood pressure is down. But no other remarkable findings on physical exam. Comes to the ED, code sepsis is initiated. Okay, so a request for step down is placed, but hospital is packed, and it might be 4 to 8 hours before a bed is ready. So principal care is transferred from the ED to the admission team. ED basically says, psh, psh, done. He's on the admit team. The admit team's upstairs with all their really sick patients. He's gonna languish a little while. Okay, that's reality. Okay, so now we're gonna say, okay, we understand there's many causes of shock. And what's really important for us to remember, that with sepsis, You move through multiple levels of shock. Sepsis is the causative factor. But when you think sepsis as a form of shock, you miss the boat. Because in early sepsis, the patient is hypovolemic. In later sepsis, the patient is vasodilated. And if not treated appropriately, at the end, they're in cardiogenic shock. So they move through all different types of shock when you're evaluating them. So historically, we're just going to say there's really 6 types of shock. Okay, I'm gonna tell you that on any exam, it's really going to be 4. I want you to think a little bit differently, but understand on an exam, it's going to be 4. Okay, 6 types of shock. Hypovolemic, pretty straightforward. You lost volume. You're an HHS, you're a DKA patient, you've been urinating all night, you're in DI, you've had a trauma, you've got a hemorrhage, you've been vomiting with diarrhea, you've lost fluid, and you're hypovolemic. Okay, that's pretty straightforward. Distributive shock. Distributive shock means you've lost the ability to maintain your vascular tone. Okay, now distributive shock truly is about loss of sympathetic activity because you have a severed spinal cord, that's neurogenic shock, or because you have circulating inflammatory mediators that promote vasodilation, that's anaphylactic shock. Now, the AACN will categorize sepsis under distributive shock. But the problem with that is that your initial presentation of sepsis is not distributive shock, it's hypovolemic shock. So that's why I categorize septic shock as a separate category. You are going to think about it under distributive because that's how the AACN talks about it. But what you want to remember is depending on where your patient is in their presentation, they'll be hypovolemic, then vasodilated, and then they'll have cardiogenic shock, and then they're dead. People die from sepsis in cardiogenic shock. Okay. All right, so we move to cardiogenic shock. That's primarily myocardial dysfunction. Could be from obstructive valvular disease, could be from severe profound dysrhythmia. Cardiogenic shock means that despite volume, despite vasopressor, your patient cannot perform normally from a cardiac perspective. Something limits that. The valves are stenotic or regurgitant. There's dysrhythmia, or there's myocardial infarct or heart failure. You're not able to have normal myocardial performance after evaluating volume, after evaluating vasodilation, you still have failure of the heart. Does that make sense? Okay. Obstructive shock. Okay. So for the exam, obstructive shock typically is the kind of shock that's going to present to you if the patient is in extremis. PEA. PEA is obstructive shock. Okay, so pneumothorax, hemothorax, massive PE, cardiac tamponade, aortic dissection. Pneumothorax, hemothorax, massive PE, cardiac tamponade, aortic dissection, all forms of obstructive shock. Obstructing the outflow of blood. Okay, because there's pressure on the ventricles and they can't fill, or because there's obstruction to ventricular ejection. Okay. Everybody with that? Yeah. So obstructive shock often leads to PEA. Okay. What is PEA by your definition?
That part has a little bit of electrical wiring, but not enough for heart or for perfusion. No mechanical, it's the absence of mechanical activity.
The presence of electrical activity and not VTAC or VF.
Yeah.
Of a what appears to be a normal PQRST, might be very fast, but it's PQRST. Usually is pretty fast, but no mechanical response. PEA is not electrical. That's why it's called pulseless electrical activity. So I see people write PEA and then the strip is VTAC or VF. That's not a PEA shock. PEA shock means you should be having a normal contraction because you have a normal electrical activation, but you don't have a normal contraction. That means all the focus on the electrical activity is worthless. Because it's not an electrical problem, it's a mechanical response. So with tamponade pneumo, aortic dissection hemo, the heart is compressed because all that extra fluid around the heart has compressed the heart. You have a cardiac compartment syndrome, basically. And the heart can't fill with volume and it can't eject it because it didn't fill it. So that's really important because all your focus in obstructive shock is to get rid of the obstruction. Okay, and then there's dissociative shock. Dissociative shock, not going to be a question on your exam, but it actually is about anything that displaces oxygen from hemoglobin. Carbon monoxide poisoning, cyanide poisoning, severe heat can dissociate your oxygen from hemoglobin. And so you've released all this oxygen, and for a period of time, your patient is going to look beautifully oxygenated, and then all of a sudden, they're going to become profoundly metabolically acidotic, and their SaO2 is going to drop severely. Okay, so that's dissociative shock. The 4 kinds of shock that the exam will ask you about: hypovolemic, distributive, cardiogenic, and obstructive. Not going to ask you about dissociative shock, and are not going to separate sepsis to a separate form of shock. So AACN will list 4 types of shock, and you've got to be able to differentiate those: hypovolemic, cardiogenic, obstructive, and distributive. And sepsis is under distributive. Okay, all right, good. So those are the 4 types on your exam. The actual 6 types of shock that you see, the clinical practice being a little bit different than the test practice. Okay, good. All right, so when we're talking about shock, it's going to be important to understand these concepts. Okay, now we've talked about these concepts before in hemodynamics, but we're going to talk about it again. That was a long time ago. Okay, so I want to make sure everybody appreciates that true preload is about the amount of volume that fills your ventricle and the corresponding ventricular recoil. Ventricular filling is preload. That's what you want to remember. Ventricular filling is preload. Okay. 2 things affect preload: the compliance of the chamber being filled and the volume that fills it. So really important to remember that pressure is more significantly affected by a change in compliance than it is by a change in volume. What's normal CVP?
6 to 10 or 40.
Okay. If you're on positive pressure ventilation, 6 to 10, around there. If you are breathing spontaneously, it'll be 2 to 8. Normal CVP. Okay, what's the difference? When you're intubated on positive pressure ventilation, your ventricle is less compliant because of the pressure changes in the chest. That's why when you're intubated on a ventilator, pressure is a little higher. Normal PA diastolic pressure, which reflects LV filling.
And the top one is 20 to 30.
PA diastolic, that's systolic.
Oh, that's
That's okay. You know the systolic. You did good, Rose. 20 to 30 is the systolic. But what's the diastolic?
10. 5 to 10. I don't know.
8 to 15.
8. Okay.
Okay. And that's going to thrust up a little bit. It's going to be 10 to 15 or so if you're on positive pressure ventilation. So PA diastolic, also wedge pressure, which is going to be very similar. PA diastolic and wedge pressure tell us about LV preload. CVP tells us about RV preload. The biggest impactor is a change in compliance. So if I have a stiff ventricle, I'm going to have a high CVP and or a high PAD because the ventricle is stiff. Now volume can't move into a stiff ventricle, so it's going to stay in the veins. It's going to engorge the veins, it's going to leak out of the veins, so you end up with pulmonary edema if it's a left heart problem, and systemic edema if it's a right heart problem. You need to memorize the normals as dictated by the AACN. Normal CVP, normal PAD, and wedge. You've got to memorize those as dictated by the AACN in order to pass the exam. I think you have to understand it more if you're working clinically, and you just need to know what the normals are. They're not going to try to trick you and say, oh, do you understand that the fact that you're giving your patient 20 a peep is what's caused this to go up? Well, they might ask you that, but probably not. That's a little bit more advanced critical thought analysis than they're really evaluating. Okay, afterload. Afterload is the tension that must be developed by the ventricle to eject blood. That tension that must be developed is a reflection of the exit valve, so that would be pulmonary for the right heart, aortic for the left heart, and the tone of the vessels. So for the right heart, the pulmonic valve and the pulmonary vessels. For the left heart, the aortic valve and the systemic vessels. Afterload is tension development of the ventricle, but we can't measure that. We can calculate it, but we can't measure it. So instead, we use a very simple calculation. That simple calculation for the left heart will be the SVR calculation. And for the right heart will be the PVR calculation. So we're going to have that in a minute. I'm just going to remind you that for the right, so just look up at me for a minute. Don't write all this down. When you calculate afterload, it's going to benefit you more to appreciate what I'm saying. The right heart is ejecting into an artery. What artery is that? The right heart ejects into what artery? PA, okay? So you need to remember that. The mean pressure of the artery the ventricle is ejecting into minus the end of that vascular bed, which will be the end filling pressure. So PA mean minus PAD divided by your total blood flow, which is cardiac output. PA mean minus PAD, that's a short circuit, and the right heart has to push the blood through that circuit. The left heart ejects where?
To the aorta.
Okay. Systemic arteries, good, the aorta. So what's that first one? It's the mean pressure of what? The PA or the systemic artery? The systemic artery. So MAP, and what's at the very end of that circuit? No, PAD is in the pulmonary valve. Does your blood stop at the capillary beds or does it get returned to the right heart?
CVP.
Okay, MAP minus CVP divided by cardiac output. Instead of always relying on some piece of equipment.
Can we write it down? Because
Yes, you can. I want you first, though, to understand it.
Wow.
The ventricle is pushing blood through a circuit.
Right.
At the beginning of the circuit is the mean pressure, and at the end of the circuit is the opposite ventricle filling pressure. So mean PA minus PAD, or wedge pressure, divided by cardiac output is pulmonary vascular resistance. Mean arterial pressure minus CVP divided by cardiac output is systemic vascular resistance. You need to understand it, because if all you're doing is memorizing, what good is that? It's worthless. You've got to understand it. My left ventricle has a huge circuit that it has to overcome.
Right,
And that MAP must overcome the terminal CVP.
right,
The mean PA must overcome the terminal wedge pressure,
right,
because otherwise blood doesn't flow.
right,
And blood doesn't stop at the capillary. It goes into the vein and it has to go somewhere else. Your left ventricle is overcoming that whole systemic vascular circuit. Your right ventricle is overcoming that whole pulmonary vascular systemic circuit. Now, I feel like that the ASN is pretty aware of the role of technology in today's world. They also probably recognize that if, for the majority of nurses, if you even ask them what the component of SVR, PVR calculations were, they do not know that answer.
Right.
They do not know. Well, I got a patient with a CVP of 20 and an MAP of 50. 50 minus 20 is 30. I have a lousy pressure gradient. Whether I know how to calculate SVR or not, what the heck? If my CVP is 20 and my MAP is 50, that's not a good enough gradient for the left ventricle to generate, to push blood through. You got to get your CVP down and your MAP up. And that is what drives your therapeutic intervention in shock. So for afterload, we're going to use a basic calculation. It's not the best thing there is, but it's what they're going to test you on. PVR for the right heart, pulmonary vascular resistance, should always be less than 250. SVR, they usually are going to correlate. It's a little different than our Phillips monitor, but it's okay. It should be just right around there. 800 to 1200. PVR less than 250. SVR 800 to 1200. Okay. All right. Now we all appreciate what cardiac output and index are. Remember, normal cardiac output 4 to 8 liters per minute. Normal cardiac index 2.5 to 4 liters per minute per meter square. And the two important components here are heart rate and stroke volume. Whenever you see heart rate is up, you should always assume that's a compensation for an inadequate stroke volume. Okay? Whenever heart rate is up, your assumption, until proven otherwise, is that it's a compensation for inadequate stroke volume. Do you have inadequate stroke volume if you're hypovolemic? Yes or no? Yes. Do you have inadequate stroke volume if you have cardiac failure?
yes,
Okay. Do you have inadequate stroke volume if you are severely vasodilated?
yes,
Okay, good. So guess what? One of the most important things you look at is stroke volume. You try to maximize stroke volume. As you maximize stroke volume, heart rate will come down, but cardiac output can stay up. Letting patients be tachycardic with low stroke volume, that is a signature of death. And by the way, happens every day. Because people are just like, well, the cardiac output's okay. Well, your stroke volume stinks. To optimize your patient, you have to raise stroke volume. How are you going to do that? Volume, inotrope. If you need to optimize stroke volume. So that's what really helps us in the understanding of shock. It's not just to memorize all this criteria, but to really understand that. Okay. Vascular resistance, remember SVR reflects the left ventricular tension or afterload. Pulmonary vascular resistance reflects the right ventricular afterload. And a lot of the drugs that we give volume, we give inotropes, we give vasopressors, they're going to affect preload, afterload, vascular resistance, and cardiac output. When I give you a vasopressor, I need to be cautious because as I titrate up on my vasopressor trying to induce vascular tone, I could actually limit stroke volume. And if you're not monitoring that, you are harming your patient. So the days of nurses like you, super smart, with a lot of autonomy, the days of nurses like you just titrating up on vasopressors to a patient's blood pressure, that needs to be over. Because we harm our patients when we do that aggressively without looking at what is occurring. Does that make sense? Okay. Rose, you all right?
Yeah, I'm good.
Okay,
I'm trying
so
to take it in.
cardiac output 4 to 8, index 2.5 to 4, stroke volume, the amount of volume ejected by the ventricle with each contraction. Normal stroke volume is 60 to 100. You have capacity to go up to 200. Anything less than 60 associated with indicators of acidosis means that you are in shock. Anything less stroke volume less than 60 associated with indicators of acidosis means you are in shock. Okay, really profoundly important. Okay, so our endpoint here is really about stroke volume. And the ACN may ask you about maximizing stroke volume because everybody talks about stroke volume, but they may also just talk about cardiac output index. So you need to know normal stroke volume 60 to 100, normal cardiac output 4 to 8 liters, normal cardiac index 2.5 to 4 liters. For your exam, you need to know that. For your practice, you need to appreciate that the appropriate cardiac output and index are the ones that answer the tissue demand for oxygen. That it may be my patient needs a cardiac output of 10 or 12 or 18. They may need a cardiac output of 3 because they're sedate with analgesia or they're paralyzed. They don't need much cardiac output. But on a test, in a textbook, you need to know the normal definitions. Good? Okay. All right. So SVR, so I gave you the basic SVR calculation, which is the MAP minus CVP divided by cardiac output. But now I just want to introduce this number 80, which is a fixed number. 80 times that product, MAP minus CVP divided by cardiac output, and then that times 80 is actually what converts it into the measurement of resistance known as dynes, D-Y-N-E-S. So again, they're not going to ask you to do the calculation. They're pretty smart. They know you don't do it anymore. It's all calculated somewhere else. From my point of view, it's a missed opportunity. Make sure people know what goes into that formula. And you don't have to have a tool. You're at the bedside, you got a mean pressure, you got a CVP, you got a cardiac output, just calculate. And you should practice that. Okay, so really important. As the SVR increases and the vessels are constricted, the difference between systole and diastole is going to narrow. That's called pulse pressure. So when you're vasoconstricted, you're going to get a narrowed pulse pressure. And when you're vasodilated, you typically are going to get a wider pulse pressure. As long as your ventricle is filled with volume and it works inotropically. So a really important concept is to remind yourself that you get a lot of clues here about whether you have appropriate ventricular function or not. And then we come to perfusion indicators, okay? So tissue hypoperfusion is going to be evaluated as metabolic acidosis. So remember, base and bicarb go down, metabolic acid is up. So when I look at a blood gas and the base or bicarb is down, they're in a base deficit, the bicarb is down, that means metabolic acid is up. Okay. The oxygen levels in your venous sample, and really it should be central venous. Okay. Oxygen, the dissolved oxygen levels are normally 45 to 55. So unlike the arterial level, which is 80 to 100, your venous level is 45 to 55. What that signifies to you is the difference between before and after the capillaries and the cells. The cells are who are using the oxygen. Okay, so between your PaO2 80 to 100 and your PvO2 45 to 55, that difference is what your cells are using. In general, although you're doing venous blood gases, so I don't know why you're not looking at it, but that's okay. In general, what you talk about is SVO2 or SCVO2, which is the reserve oxygen bound to the hemoglobin after first pass through the capillaries. So Normal SVO2 measured from the pulmonary artery catheter distal tip, 60 to 80%. Normal SCVO2 measured from the brown lumen or the distal lumen of your central line, 65 to 85%. That means that's your reserve oxygen. So you went out at 100%, you return at 60%, your patient used 40% of the oxygen that was available. The role of your hemoglobin is solely this: to carry oxygen and to release it if the cells need it and if they can get it. If cells need it and cells can get it. So SVO2 measures the presence or absence of reserve oxygen. Now, if I have a lousy cardiac output, do I have good delivery or not good delivery? Not good delivery. Am I going to die in that moment? No, because I have a reserve. So when I have a lousy cardiac output, I'm going to use oxygen from my reserve, which means my SVO2 is going to be low because I used oxygen from the reserve. Mallory, are you good with what I just said? You feel comfortable with that? Okay, good. Excellent. So, by the way, that's going to be integral in evaluating shock. It's going to really help us in understanding shock. So remember, we're going to look at heart rate, respiratory rate, indicators of hypoperfusion. That'll be metabolic acidosis, lactic acidosis, base bicarb, SVO2 or SCVO2. And then we're going to say, do you have volume? Yes or no? And where is it? Because if I'm hypoperfused, but I have high venous pressures, I have volume. But the volume's in the veins and not in the arteries because of change in compliance of the ventricles. So everybody good with what I've just said? So this is going to be a really important concept when we're evaluating these types of shock. Okay? So it's a big bowl of information. It's not just he's got a temperature, his heart rate is up, his respiratory rate is up. It's okay, what's the big bowl here? What else is going on that I can evaluate in relationship to that patient? Oops. I forgot about this noise. I should have turned that all off. Okay, so inadequate volume. I'm going to remind you, inadequate volume means that you actually have low total volume. You've lost a lot of volume through diarrhea, vomiting, diabetes insipidus, HHS, DKA, dehydration. You've lost volume. And that's a total volume loss, both venous and arterial. But there is the other form of hypovolemia. We're not going to call it hypovolemia. But there is another form of hypovolemia, which is low arterial volume. You've got volume, but it's not in the arteries. Okay. So when you're looking at a patient for hypovolemia, you can see that they have neck vein distension and bilateral pitting edema. But if they're also hypotensive and their urine output is down, they are still hypovolemic in the place where volume matters, which is in the arteries, because in the arteries is where we're delivering flow and delivering oxygen. Good? Okay. So a lot of things that you can look at here. And of course, the most significant one and the easiest one for us to diagnose is hemorrhagic shock. You're bleeding. You were bleeding on the street, came into the ED, you've lost 4 units of back cells. We're giving you 8 units of back cells. You're in hemorrhagic shock. Right? We're always going to assume with the rapid respiratory rate and a fever that you've lost volume. Faster you breathe, more volume you're going to lose. Because you're using your own endogenous volume to humidify the gas you're breathing. When you're training a lot of gas, you're breathing really fast, you're going to lose a lot of volume in that way. That's really insensible. We can't calculate it, but we need to appreciate it. Okay, gonna hear those things again? Oh, good, I'm glad not. Okay. Second thing is inadequate heart, and that's your cardiac output. Now, remember, if I don't have enough volume, I'm gonna have an inadequate cardiac output. So not having volume creates a really easily therapeutically altered form of cardiac shock because I don't have enough volume. But I also can have volume in the vein, but not in the artery. When I have volume in the vein, not in the artery, the problem is the heart, always, always. Volume in the vein, not in the artery, the problem is the heart. You might be 22, but now through the 5 days that you've been in the ICU, you now have a form of heart failure. You got volume in your veins, but not in your arteries. You're on 50 of norepi, you're on 10 of epinephrine, you've got 6, 8, 10 over the course of 5 days, 12 liters of volume. You got volume in the veins, but your urine output is down, your BUN and creatinine are elevated. You have volume in your veins and not in your artery. This is a cardiac problem. Patients will do much better if you recognize that earlier. Okay. All right. So inadequate heart rate, too much work that the heart's doing, abnormal rhythm, all the kinds of things we mentioned before. And then last, but certainly not least, is the loss of your vascular tone. And that's really about the arterioles and the capillaries and how blood flow is provided through those vessels. Okay. So inadequate vascular tone is really about the loss of ability of the vessel to constrict or dilate depending on the flow property, meaning how much volume is in the artery. Okay, so what makes you lose vascular tone? Inflammatory mediators. Now, inflammatory mediators are released in sepsis. Inflammatory mediators are released in anaphylaxis. So inflammatory mediators cause you to vasodilate. So if there's suspicion of anaphylaxis or proof or suspicion of sepsis, you're going to assume vasodilation. And it may not occur immediately, it may occur later, but you're always going to consider that. The only treatment when you have dilated your vessels, which you've lost your ability to maintain vascular tone, you're going to try to fill the vessel with some volume, but then you're going to vasoconstrict. So the only treatment is actually the application of vasopressors. Okay, really, really, really important. The other form of that loss of vasculars, two more probably that are not always so obvious. One of them is post-anesthesia. It's highly documented, post-anesthesia vasoplegia. So by the way, patients coming from the OR to the ICU will typically get boluses or push of neosynephrine, which is highly indicated for post-anesthesia vasoplegia. Does not necessarily mean that when the patient arrives to your unit, you're going to have to put them on norepinephrine or epinephrine titrate up, because this is a limited response to the anesthesia that they receive. So post-anesthesia vasoplegia. And that's very highly common to see in patients post-OR. So they're coming to the ICU from the operating room, anesthesia is giving them 2 pushes of vasopressin, brings them in, they say their pressure is fine. What they really mean is they drop their pressure, but we think it's a vasoplegia from the anesthesia and I treat it with neosynephrine. They don't say that, they should. They should be saying it because that prepares you to actually say, is this continuing on? And is this still vasoplegia from anesthesia, or is there a secondary problem? And how am I going to deal with it? And it helps me to be prepared if they're telling me that they've had to do that. Okay. But the other form is, of course, severe metabolic acidosis. Metabolic acidosis, typically with a pH of less than 7.25, will actually promote vasodilation and resistance to catecholamines. So very, very, very important. All right, so now if I just look at the I don't even have obstructive shock up here. I just feel like that's so straightforward. If I look at hypovolemic shock, cardiogenic shock, compensated sepsis, which is basically hypovolemia, and decompensated sepsis, okay? Really, really important. Okay. You can see for hypovolemic, cardiogenic, compensated sepsis, and decompensated sepsis, all of them have poor capillary flow. They all have a problem with blood volume and blood flow, right? That's what made you in shock. Everybody with me? So at the capillary level, there's no recognition of the difference. It's all shock, okay? But the difference is, are you able to attain or maintain vasoconstriction? In hypovolemia, you can vasoconstrict. In cardiogenic shock, you can vasoconstrict. In sepsis, you don't vasoconstrict. You've lost your vascular tone. Okay? Until you decompensate. And let me just say this. It is not like your vessels all of a sudden say, hallelujah, I found Jesus, I'm vasoconstricting. It's that you are monitoring their SVR, which is that a measure or a calculation? A calculation. And in decompensated sepsis, you are not regaining your vascular tone. You have lost your cardiac output because you are now in cardiogenic shock. So cardiac output is the denominator, MAP minus CVP divided by cardiac output. So now look over here at stroke volume. For hypovolemic shock, stroke volume's down. Cardiogenic shock, stroke volume's down. Compensated sepsis, stroke volume is up. That's why you give that patient volume. They manage their stroke volume, they increase their stroke volume. But when they decompensate, look exactly what they look like. Exactly look like cardiogenic shock. Because that's how they die. Does that make sense? You feeling pretty good about all things shock right now? All right, awesome. That's really important. Thank you. So remember, they all share that capillary flow. When we talk about hypovolemic shock, low total volume, low flow. Cardiogenic shock, high venous volume, low flow. Compensated sepsis, high arterial volume, high flow, but down at the vascular level, we're altering perfusion. Decompensated sepsis, high venous volume, low flow. Exactly the same as cardiogenic shock. All right, I'm going to stay here for a second because I know you want to take a picture. Really, really important. So what am I going to look at? I'm going to look at your volume. I'm going to look at where your volume is. And basically I can say stroke volume and CVP. Stroke volume and PAD. Blood pressure and CVP. Blood pressure and PAD. And basically on a test, it's not going to be complicated. You're going to see that your filling pressures are high and your blood pressure and stroke volume are low. That's cardiogenic shock. Your filling pressures are low and your blood pressure and stroke volume are low. That's hypovolemic shock. Your filling pressures are normal. Your stroke volume is high, but your blood pressure is low. That's septic shock. It's pretty straightforward on a test. In reality, not so straightforward because you've got lots of complications. But on a test, it's really straightforward because a test isn't testing your ability. This is not the MCATs and it's not the medical boards. They're asking at the most generic level, can you recognize shock? And it's shockingly amazing that a lot of times we're not really recognizing shock because we're kind of always waiting for blood pressure to go down. That's the last thing that happens because your patient compensates for that, right? So we have to recognize those compensatory signals. That's what's so significantly and profoundly important. Oh, whoops. So everybody has metabolic acidosis and a base deficit. Okay. And typically SpO2 will be low. Okay. All right, so we go back to Mr. CJ, remember him? So per the sepsis hospital protocol, he gets a full panel of labs and a blood culture drawn. Within 30 minutes, this is actually happening, and he gets 30 mLs of lactated ringers, okay, per kilogram. So it's about 2.5 liters. And he also gets broad spectrum antibiotics. And you're asked a question about the most important thing in a septic patient. Is it volume or broad spectrums? In a septic patient, what's the single most important thing that actually preserves their life? Antibiotics. Antibiotics. Which means if you can't get a blood culture, you still give broad spectrum antibiotics. You do not wait for a blood culture. Antibiotics is the single most important tool in saving someone's life from sepsis. Volume is very helpful because they're presenting with hypovolemic shock, but you got to stop that inflammatory nidus. Now, really, the best thing is to do them both at the same time, obviously. Okay, and it's much easier for us to give volume. So while you're waiting for your broad spectrums, you're giving volume. That's why, Rose, you say volume because rapid response is given volume, but you're trying to get the broad spectrum as well. But the most important tool that saves lives is early broad spectrum antibiotics.
Because it's like all the time, we try to give, they will never give you antibiotics. It's like you have to keep forcing it. They're like, no, just
That's
do
why
vitamin,
there's so
that's
much
it.
death from sepsis.
Yeah. And they will not give you antibiotics. They wait till like the hour is over, I'm like, it's done.
Well, what they do and what's right to do are not the same thing.
Because immediately we always ask them for antibiotics, they'll never give us.
I always say, if your residents are not giving you what you need to call the attendant. Seriously, you've got to escalate because your patient's life is at risk. So we're very aware of it. In the sepsis team, the sepsis committee, we continuously track all this. And there's always a lot of discussion about why is it that the residents aren't giving the order for antibiotics? Why are they waiting? Why are they doing this? And then there's all the confusion with the attending people and now the new chair of the sepsis committee. It's just all very confusing. It is clearly evaluated that broad spectrum antibiotics is the single most important thing, and it has to be done quickly. Has to be done usually within 30 minutes to 60 minutes of identification. So always ask for them. Don't get into a conflict. Call the attending, say the patient appears septic, can we give an antibiotic? The attending says no, and a lot of times, you know what, even if they know it's the right thing to do, they're going to support their resident.
Yep.
Because it's like, oh yeah, this is a minefield of practice here. Are you kidding me? Stop it. Treat these patients right. Okay, sorry. All right, so he got volume, he got his broad spectrum within 60 minutes of his arrival. His temp is 39, heart rate is 118, down from 125, respiratory rate 22, down from 24. His blood pressure's come up a little. White count is 22, lactate is 2.6, troponin, that's point of care troponin, so yes, that's normal. And his bicarb is down and his gap is wide. Okay, so does he have metabolic acidosis? Yes or no? Yes. Do you feel like he's headed in the right direction?
Yes.
Because his vital signs are improving, correct? Everybody good? So now we do, all his other labs are pretty normal. We do a bedside echo and he has an EF of around 58%. So once you see he has an EF of 58%, are you comfortable with giving him more volume? 100%. You need a targeted endpoint for volume, and that would be your stroke volume, but you feel that the heart can handle the volume. Okay. All right, very good. So you like the way he looks? You feel like he looks better, right? And he doesn't really. I mean, he does. You know what? He looks better here. So here's the problem. We're all tunneled. We're tunneled.
The lactic.
And we're saying, hey, he looks much better. Rapid can go back to wherever they go. Nobody needs to be worried. And here we are, 2 hours later, blood pressure drops to 88/40. Nurse calls the primary team. Takes 20 minutes for that team to respond and determine that they want to give more fluid, and they're going to give him another 40 mLs per kilogram. His level of consciousness starts to deteriorate. This is a real patient. He's obtunded, and he only wakes up when his name is called and you're shaking him. Skin now is warm to touch, he's flushed, and he has 4+ bounding pulses. Does he have sepsis?
Yes.
Yeah.
Does he have septic shock?
Yeah. It's
Okay,
early.
because now for septic shock, The only difference between sepsis and septic shock is the blood pressure. Now he is hypotensive. He's much farther down the line because we felt really good about where he was and we didn't do anything. But Rose, what did you see? His lactate was still elevated and he was still acidotic, and we didn't do anything else. So 2 hours later, he deteriorates because we didn't do the right thing at the time, because we felt good. He looked pretty good, right? He looked good. He looked like he was headed, and he was headed in the right direction, but we said that's enough. He said in the right direction. Yahoo! But his lactate was still elevated and he had metabolic acidosis. He was still tachycardic, he was still tachypneic, it just improved. Okay, so.
Is it time for an item?
Yeah, no, that without looking at the code. Okay, so he is not better, right? All right, so could be time for an inotrope. I mean, you have to really look at the patient. It's not, okay, now I'm gonna give you an inotrope. I'm gonna look at you. I'd like to look at your EF, your pulse pressure. There are a lot of things I can look at. What is your stroke volume? And remember, our cardiac output goal is to get the heart rate down and the stroke volume up while maintaining the cardiac output that answers the cellular demand for oxygen. So we're gonna resuscitate your volume first. You may not have gotten enough volume, and I have to know what that target is. And then I might put you on a vasopressor, that's fine, but the vasopressor is not treating the, well, I love what you said, Rachel, but I'm gonna say it differently than that, because the problem is that you're septic. So you need antibiotics, that's the problem. But when I give you a vasopressor, I'm just enhancing vascular tone, I'm not improving blood flow. So I need to enhance your vascular tone and increase your blood flow. So that's why I might put you on a vasopressor. I might also give you a little volume. And then I'm going to consider an inotrope because I need to resuscitate your stroke volume. Vasopressor does only one thing, vasoconstrict. It doesn't improve your stroke volume. And in fact, it can limit it. So that's where we have to be cautious. We have to evaluate our patients, see what it is they really need. The other thing is that we're actually trying to improve the delivery of oxygen, which we do best by manipulating the cardiac output. And as we increase the oxygen delivery, cellular metabolic dysfunction, therefore metabolic acidosis, will start to reduce. So my goal in shock is to increase your stroke volume, and I see your heart rate come down, but you have a good cardiac output, and to improve your oxygen delivery. Normally, I'm going to do that by enhancing your cardiac output. It's not really effective. Your SAT's 88%, you're going to be okay. Typically, we don't give red blood cells unless our patient is just completely resistant to all other therapies, or they've been proven. And I want to see that your metabolic acidosis starts to clear. So your metabolic dysfunction decreases as I increase the delivery of oxygen. That's my goal in shock. That's so important. So again, I want to remind you, your focus here is stroke volume. Normal stroke volume 60 to 100, can go up to 200. Anything less than 60, you have to be concerned. Now, if the patient is completely normal, has no base deficit, bicarb not down, not tachycardic, and he has a lower stroke volume, maybe that's because you've adequately sedated him with analgesia or because he's paralyzed. He's cool, but somebody who's got a temperature, their demand is going to be high. So they're going to try to meet that demand with tachycardia and tachypnea. Okay. I like to remind everybody that measuring stroke volume is the way we at the bedside can measure left ventricular effectiveness. So for us, our primary mechanism hemodynamically is to look at arterial-based pulsatile cardiac output, which looks at the area under the curve between systole and diastole and calculates that into a stroke volume. And that's going to really help me to evaluate my patient. If you don't have that, look at pulse pressure, systole minus diastole. You need that to be greater than 35 your patient has any indication of acidosis. So on your exam, you may not always have a cardiac output or a stroke volume, but you'll have a pulse pressure. That pulse pressure needs to be greater than 35 if you're trying to resuscitate acidosis. Okay. Oh, just want to remind you, I think we've seen this before. We talk a lot about pressure. We talk about arterial blood pressure. We talk about PA pressure. We talk about central venous pressure. Pressure is always about the relationship of volume to compliance. So can I get your blood pressure up aggressively by giving you volume? Can I get your blood pressure up aggressively by giving you volume?
No.
I'm gonna get your blood pressure up aggressively, typically, by giving you a vasopressor. Because I'm gonna change your arterial compliance. I can give you a lot of volume, and if you have vasodilation, your blood pressure is not gonna come up much. Okay? So we always try volume. We always try volume. And remember, when we give volume, what we're resuscitating is systolic blood pressure. But if diastolic pressure is low, that means your mean pressure will be low. If diastolic pressure is low, you need a vasopressor. So if your patient's diastolic pressure is less than 40, you gave volume and diastolic pressure didn't budge much, even if systolic pressure did, you need vasopressor. So you're going to gear that vasopressor towards the response of the diastolic pressure. And what you want to remember, big volume in a compliant chamber causes very little pressure change. What causes pressure change is a resistant chamber. Now, we're talking about the arteries, we're talking about making the arteries resistant, but I also want to remind you that when you have an elevated filling pressure, CVP, preload pressure, CVP to the right heart, PAG or right to the left heart, those pressures typically go up because the ventricles have lost them. Because normally the right ventricle is very, very compliant. The pressure doesn't go up when you get volume. So really, really, really important. CVP, which is going to probably be the most common method for you, and on your exam, the most common method of really evaluating ventricular efficiency. When CVP is up, are you going to have volume in your veins? Yes or no? When CVP is up, do you have volume in your veins?
Yes.
Because your ventricle cannot accept the volume. And typically, the reason is you have lost ventricular compliance. Okay? All right, now, after 30 minutes of relative hypotension, Mr. CJ receives an A line and a central line, start on norepinephrine at 4 milligrams, and he's transferred from the ED to the ICU. Okay, 30 minutes. 30 minutes of hypotension. Has he already got organ dysfunction?
Yes.
Yes. 30 minutes of hypotension is unacceptable. You don't want to really have a continuous hypotension for more than 5 minutes. You'd like to have less than 3 minutes, but it's a little bit hard to manage your patient that quickly. 30 minutes of relative hypotension, unacceptable. Okay, so we're going to resuscitate that blood pressure. Now, we're going to remember that we're going to try to make this all meaningful by correlating it to your stroke volume. And what I want to tell you is that all the current information says you need a stroke volume indicator. So that could be just pulse pressure. It could be arterial-based cardiac output with a stroke volume measure, but just pulse pressure and CVP. And you need both, not just one. You need CVP and stroke volume to actually resuscitate the patients effectively. Now, we've talked about stroke volume before, so I'm not going to spend much time on that here. I just want to remind you that CVP tells me where your volume is. If CVP is elevated, your volume's in the veins. That's what CVP tells me. CVP will be elevated when I have cardiogenic shock, when I have cardiac dysfunction. Even though I didn't have heart failure when I came in the hospital, I've got an elevated CVP now, but I'm hypotensive. I have decreased urine output. I have acute kidney injury. I've got volume. It's in the wrong space. It's in the veins. And giving more volume is not going to make that better. I have to now look at the heart. I have to now consider, is there obstruction of blood flow from right heart to left heart? And I'm always going to consider that. Now, the way we talk about this is with the Frank-Starling law. So Frank-Starling means I'm going to look at CVP and stroke volume, and on the test, you will also apply this. You gave your patient 2 liters of volume, their CVP went from 10 to 11, and their stroke volume went from 30 to 40. Did your patient respond to volume? CVP went from 10 to 11, stroke volume went from 30 to 40.
Yes.
Yes. You give another liter of volume, CVP went to 13, stroke volume went from 40 to 41. Did your patient respond to volume? No, good, exactly right. You have to be able to look at your patient's volume response. That's when you're gonna say time frame. Because you must know that they have failed volume before you add a nitrogen. And you can't know that without a target. The target is, I'm okay with your CVP going up as long as your stroke volume goes up. If your CVP goes up and your stroke volume doesn't go up effectively by at least 10%, you're not getting any more volume. Okay?
So, without the CVP, how do we see that? Like,
Neck vein dissection.
okay,
Evaluating the neck vein using POCUS, seeing if the neck vein is compressible. The neck vein is uncompressible, means it's got a lot of volume. So at that point, you're gonna say, well, the neck vein is not compressible, it's distended, it's dilated, I've got volume, but I'm still hypovolemic. Now I'm gonna say, oh, I think I might need an nitrogen.
yeah, because I'm just saying, like, when we in the, sometimes we're not in the ICU setting. We're on the floor. That's why I want to know
Okay,
if we
but
don't have a CVP.
on the exam,
Oh, it's okay.
no, I'm saying on the exam, I think you'll have all the tools you need. So you'll either have a note that says CVP is 12,
Okay,
or a note that says neck veins are plethoric, meaning non-compressible. They're highly distended, filled with volume. Okay, so they'll tell you. They just need to appreciate that you know how to interpret that. But when you're on the floor, what you're actually looking at is if I give you volume, you become more tachycardic. If I give you volume and your neck veins get more distended, if I give you volume and you get increasingly short of breath,
yeah,
volume was not the answer, right? So it's less direct, but still valuable. We have to think about it. Everything that you look at that tells you about where volume is, you should be applying here. If volume is in the veins, if it's in the pulmonary veins, you're going to get short of breath. If it's in the systemic veins, your neck veins are going to engorge. So everything we know about where volume is, we should be able to apply on the street. Somebody passes out and you're looking at their neck veins, and then you say the neck veins are flat, I'm lifting your legs up.
right.
Your neck veins are distended, I'm probably not going to lift your legs. Because you got volume and it's in the wrong place, and I'm going to cause more damage by lifting your legs up.
Yeah.
I'm just on the street, I have no other tool. Right?
Yeah.
Okay. Cool. Okay, excellent, excellent. So the thing about stroke volume, remember, there are 2 things. First of all, if I've got an A line, because that's really where it's going to be the most meaningful, I'm looking at your systolic pressure. Systolic pressure is what's most significantly affected when I increase stroke volume. Systole represents LV ejection. So very, very important. Any functional myocardium, when you give volume, you should see an increase in systolic pressure. When you give volume, you should see an increase in pulse pressure. When you give volume, you should see an increase in stroke volume if the myocardium is functional. If the myocardium is not functional, you're not going to see that. And that's really the Frank-Starling principle. Functional myocardium will increase stroke volume when tissues are acidotic. A functional myocardium will accept the volume you gave and eject it. And at some point, when you're over resuscitating, you will make the ventricle non-functional or dysfunctional. And that over resuscitation is volume and vasopressor. So again, I'm just going to go back to the EG. Got a patient who's hypotensive, who's on 4 of norepinephrine. The nurse doesn't like the blood pressure, and they take that 4 of norepinephrine and they put it up to 20.
Oh, geez.
Straight up to 20, because I'm going to get that blood pressure up. Okay. That's like life threatening. Because you don't know about the function of the myocardium. And when you do that in any patient, you create that much vasoconstriction has a huge load to the myocardium and can actually cause cardiac arrest. It's really important to say each step I make, I can do steps quickly, but I need to give time for response so I can truly evaluate what's occurring. The same thing on the exam. You got to evaluate every intervention to assure that you're doing the right thing. Okay? All right, so just reminding ourselves that really the most important thing when we talk about stroke volume is about achieving a better delivery of blood flow and oxygen. So here are multiple ways we can do it. Okay, so on your first scan, this is from the cheetah or the starling, which is bioimpedance electrodes placed on the chest wall. That's going to give you cardiac output, cardiac index, stroke volume. Next to that is the non-invasive methodology called the clear site, which is giving us also cardiac index and stroke volume. The index is the second from the bottom, 2.7, and then the stroke volume is on the bottom, 48. Next to that is actually connected to an arterial line, giving us our cardiac index and our stroke volume. Also calculate SVR. And after that is actually looking at your ventricles with an echocardiogram. By the way, there's never an excuse for us to say we don't know how the ventricle is performing. I always have to point out. Systolic pressure, pulse pressure, non-invasive, invasive, minimally invasive, echocardiogram and POCUS. And it's unacceptable to say, I have no idea what's happening. You got to know what's happening. So you're going to look at that response, okay? So I just want to remind you, CVP is not a volume number, it's a pressure number. And it's about the compliance of the right ventricle, which in and of itself can become non-compliant, but you've had an RV infarct, you have a PE, you're on positive pressure breathing, or it could become non-compliant as a secondary effect from LV non-compliance. We're going to use CVP as a pressure number. It is not a volume number. Stroke volume, though, just by the word, it's not stroke pressure, it's stroke volume. That's a volume indicator. So we use one volume and one pressure, and that helps us to better define what's occurring for our patient in the eyes of Frank and Starling. And that means I'm okay if your CVP goes up as long as your stroke volume goes up. And every time I give patients an aliquot fluid 250 cc's, or I do a passive leg raise and lift their legs and give them their own bolus, I'm going to expect to see that their stroke volume goes up. If their stroke volume doesn't improve with administration of volume, volume is not the answer. Stop giving volume because aggressive volume resuscitation can cause significant and profound problems. Good? Everybody happy with that? Okay, perfect. So now we're just going to look at a quick application practice. Okay, so let's say we do a passive leg raise. That might be a question on the exam. Passive leg raise gives the patient his own volume from his legs, and when you put the legs down, the volume returns to the legs. Passive leg raise, or you're giving a 250 cc volume bolus. Okay, so you're giving, it's not really a bolus, it's a challenge. You're going to give that volume in less than 3 minutes. It's a challenge, it's not a bolus. Don't do 999 on your pump. You're giving it really fast under a pressure bag as fast as you can to see how the ventricle responds to that challenge. Okay, that should increase the volume at the end of filling. And that for us in this scenario is going to be reflected as CVP. Okay, and that should impact your stroke volume. So for every challenge of 250 to 500, your stroke volume should increase at least 10%. But that's not really that much, because if your stroke volume was 40, I'm only asking to have an increase of 4. So now from 40 to 44, I'd give you more volume and I see you increase to 50. You responding. But really, really important, and we're going to apply this on our exam. We're going to apply it in practice, and we're going to remember that when your patient has volume that they can't mobilize, vasopressor is not going to touch that. Suppressor is about vasoconstriction. It's not really about cardiac support. And as much as your docs would love to say, well, norepinephrine has beta effect, norepinephrine, Levophed is not a profound beta stimulant. You have to put your patient on beta stimulant. That would be dobutamine or dopamine, or not my favorite, but yeah, if that's all there is, or that's all my doc's gonna do is epinephrine. I'm not in favor of epinephrine because it has anything else. But I need to be sure that it ends up in the systemic artery. If I give you volume and you get more and more and more venous engorgement, but you're saying still profoundly hypotensive, didn't end up in the right place. Stop giving volume. Your patient now needs to, for consideration for an inotrope. Cool? All right. I want to make sure you remember the only reason we gave you volume was to increase your stroke volume. You've got to look at whether or not you've increased stroke volume. Okay. So I think we've done all these things. Repeating them, but I'm going to come here just to remind you about the base deficit. Okay, but we're going to use base deficit when we're evaluating the resuscitation that we've applied to our patient. I want to remind you that you really don't care about base, it's just that's what you have. What you really care about is metabolic acid, which you can't measure. Okay, so normal metabolic acid concentration is 40 nanograms or nanomoles per liter. Okay, and that's what gives you a perfect pH, 7.4, 40. For every 10 hydrogen ions that go up, your pH will drop 0.1. So for every 10 hydrogen ions that go up, your pH will go down 0.1. You don't measure hydrogen ions. You don't even really care that much about what I just said. What you really care about is that circulating base, of which bicarb is the most important, are designed to do one thing only, and that is to buffer hydrogen. So when hydrogen is up, base and bicarb are going to be used to buffer, base and bicarb are going to go down. When base or bicarb are down, your assumption is you're using it to buffer metabolic acid. Everybody good with that?
And that's why it comes down, because they're used to it.
Because it's no longer base or bicarb, it's now a different molecule.
Okay.
Because you used it.
Yeah.
So when you're using it, it goes down. It means you need more because you have so much metabolic acid that's got to be buffered. And if you have AKI, kidney is responsible for the clearance of hydrogen ion. If your kidney can't clear hydrogen ion, your base deficit is going to get worse, because your kidney can't excrete the hydrogen. Okay. So we're going to use base, and on your exam, you will probably get in your case studies, you will either get base or you'll get bicarb or you'll get both. Okay, it's okay, just don't freak. Base deficit and bicarb travel in the same direction. So if my base is in deficit, my bicarb is coming along. Okay, so if you've got base deficit, that's what we do here. Or you got bicarb, it's okay. When those are going down, metabolic acid is up. That's all you have to remember. Now we like base deficit because it's a calculation of circulating buffers. So it gives a little more weight to some of the other buffers, but it doesn't really matter. Big four questions. Whenever you see base deficit, big four questions. Number one, is my patient ketotic? Number two, does my patient have acute kidney injury? Number three, do they have a high level of a circulating buffer that actually converts into a strong acid, and that's chloride. When chloride binds with hydrogen, it makes hydrogen chloride, which is very acidotic. So what I can look at, ketosis, AKI, hypochloremia, and of course, lactic acid, which is a generalized indicator of tissue hypoperfusion for your exam. Okay. For your exam. So on your exam, you're going to suspect ketosis if the glucose is elevated. They're not going to be asking you complex questions about euglycemic ketosis. If your patient has ketosis, they will have elevated glucose. Now that probably is gonna change on 4 years on the exam because we're seeing so many euglycemic ketotic patients now, especially with drugs like Ozempic and other agents like that. But on the exam, it will be clear. My patient's blood glucose is 350 and he's acidotic. Is there a possibility he has ketosis? Yes. Okay. Really important. So all I'm doing is saying, what's your glucose, what's your creatinine, what's your chloride, and then I'm going to assume lactic acidosis, but I'm also going to measure it. Right? If your ketone, if your glucose is normal, your creatinine is normal, your chloride is normal, I'm assuming lactic acidosis and hypoperfusion until proven otherwise. Cool?
I'm sorry, can you explain the fluoride one more time?
Okay, so when bicarb binds with hydrogen, it makes H2CO3, right? Bicarb is HCO3. So you probably should look at me, you're not gonna see it up here, okay? Sorry. So when bicarb binds with hydrogen, bicarb is HCO3 negative. Hydrogen is positive, so they're very attracted to each other. Negatives and positives are attracted. It makes a weak acid. That's called carbonic acid, H2CO3. What's so fantastic about H2CO3 is that as it travels in the blood, into the pulmonary bulb, it dissociates into water and CO2. So what am I going to do? I'm going to blow that off, right? Good. When hydrogen marries chloride, it doesn't make H2CO3, it makes HCl. HCl is, think about it as hydrochloric acid. It's not hydrochloric acid, it's hydrogen chloride, but it's like hydrochloric acid, it's a strong acid. Can that dissociate in the lung and be blown off? Yes or no? That's it. When chloride is elevated, bicarb will be down. You will waste bicarb when chloride elevates because there's only room for a certain content of these ions. The only reason patients get hyperchloremia is because you're giving them sodium chloride. Okay. That's why over the last few years, you've seen a complete shift from aggressive resuscitation with sodium chloride to the use of lactate hospital. Because sodium chloride is and cost. Okay, did that explain it? Okay, good. It's just nothing up there is going to tell you that.
I'm in my person, I get when you talk, I get like a picture and I'm drawing it up in my head.
Okay,
So.
I couldn't tell if you were like, I couldn't tell if you were drawing something in your head or you're just like, okay, whatever she's saying, I'm not listening.
No, I'm drawing it out in my head. I'm not
Remember,
great with eye contact.
Remember, I've been spending the last 5 days on suicide watch with somebody very disengaged, but I would have to say, look at me. Because you're all, no, it's okay. I'm not going to ask you again. Look off to anywhere you like. All right, so at metabolic acid is up, base and bicarb go down, pH goes down. Good. That's a sign of shock. Right? I have indicators, CVP is up, stroke volume is down. My base and bicarb are down, which means my metabolic acid is up. Is that a sign of shock? Yes. Whatever the blood pressure is, that's a sign of shock. Okay. Then we go back to anion gap. Remember, the anion gap basically looks at measured positives and unmeasured positives. Measured positives are sodium and potassium. Unmeasured positives are hydrogen. So now you see I've added H plus Na plus K minus chloride and bicarb. Normally, chloride stays about the same, might go down a little, but bicarb drops aggressively. That's what gives you the gap. It's the presence of the unmeasured cation, which is hydrogen, and the consumption of the measured anions, bicarb and chloride. I'm consuming them because they're being used to buffer hydrogen. That's what gives me a gap. So if your gap is greater than 20, that always indicates severe metabolic acidosis. Doesn't tell you why. It just says you've got severe metabolic acidosis. If you've got severe metabolic acidosis, do you expect the heart rate to be up? Do you expect the respiratory rate to be up?
Yes.
And eventually, do you expect the blood pressure to be down?
Yes.
Yes. Okay. But let's trace it back here. and say, I have a patient with a gap of 24. And he already got 2 liters of fluid, and he looks a little better than he looked before, but his gap is 24. Is he better?
No.
No. Is he on his way? Maybe, but we're not done. We're not gonna give him 2 to 4 hours to decompensate because he's sitting in the ED or on a medical surgical floor waiting for an ICU bed. Or he's in the ICU room, we're letting him decompensate for 2 hours. We're gonna pay a lot of attention to all things about shock. Okay, so now we add this, right? My patient's metabolic acid hydrogen is up, so the base and bicarb are low. The pH is down and the gap is wide. Base deficit, low bicarb, wide gap, metabolic acidosis. Metabolic acidosis, big 4. What are they? Number 1. Just gave you the big 4. What are the big 4 reasons?
Lactic acidosis.
Lactic acidosis, that's the bottom one, but thank you. Okay,
Ketosis.
ketosis. AKI, acute kidney injury, because the kidney does what? It wastes your metabolic acid. So when you have acute kidney injury, you're retaining that metabolic acid. AKI, and the last one is high fluoride. 4 major events. Ketosis, AKI, high chloride, lactic acidosis. Okay, are there other things? Yes, many. But we're gonna remember the big 4 in critical care. Okay, cool. This seems pretty straightforward. All right, awesome. Okay. Now we're gonna add in SVO2 and SCVO2. Ooh, we're doing really good. I'm so happy. Okay, so I want to remind you that either if I draw a sample from the brown lumen of my central line, or I draw a sample from the distal tip of the PA catheter, what I am evaluating is the amount of oxygen that is still bound to hemoglobin because I didn't use it. Okay, it's a reserve. So it doesn't matter which one I measured from. What matters is understanding that SVO2 or SCVO2 tell me about the content of the reserve. Did I use oxygen? Because if I'm using oxygen and I'm using it at a high rate, the hemoglobin will release oxygen so it can be used at the cell. The only way I can use oxygen is if it's dissolved in the blood. I can't use it when it's bound to hemoglobin. It has to come off the hemoglobin, dissolve in the blood to be used at the cell. Does everybody understand that?
Yes.
Okay. So why is this important? It might be, but that's not to do with, I know that was great. That's about dissociation shock,
Okay.
and that's perfect, but we're talking about just simple shock. Simple shock. If I believe you're in shock, and you have severe, so really here, draw that picture in your head, you don't have to look at me. So you have severe metabolic acidosis. I believe you're in shock. You have tachycardia, you have tachypnea, you have high temperature, you have a low blood pressure, and you have severe metabolic acidosis. Would I want you to release that oxygen to answer the call for your cells?
Yes.
So would I anticipate your SVO2 would be low?
Yes.
Fantastic. If your SVO2 is normal to high, is that going to be normal? Very, very important. If I perceive that you have shock and I do an SVO2 or SCVO2 measure, and I'm just going to say SVO2, but just remember it means SCVO2 or SVO2. I do an SVO2 or an SCVO2 measure, and that measure is normal, and you're in shock with metabolic acidosis. My God, you're probably going to die.
Right.
Because you need the oxygen. I know that because of your shock signals and the fact that you're acidotic, you need it. But you can't get it. You can't get it, perhaps because with sepsis, you have microocclusion, you have small consumption of all your clotting products and the small vessels. It's pre-DIC, but it also can occur when you were using aggressive vasopressors. pressors. All right, I'm gonna give you a sample in just a few minutes. Okay, so normally we're just gonna use a generic range, 60 to 80%. That's a normal reserve oxygen on hemoglobin. If you're in any kind of shock, I will always expect that number to be low. If that number is low, you have dipped into your reserve and I must resuscitate you. What's the number one resuscitation that I'm going to do for oxygen delivery? Am I going to resuscitate your cardiac output, your hemoglobin, or your SaO2? Okay, and I'm going to resuscitate cardiac output with volume and inotropes. Okay, I will resuscitate your hemoglobin if you were bleeding, if your red cells are low. But the number one determinant of oxygen delivery is cardiac output. Good? Feeling good about that?
Yes.
Okay. But if you have a normal SpO2, normal or elevated SpO2 with profound metabolic acidosis, I have to figure out, did I cause this with my vasopressor? In which case, I did the wrong thing. And I have to be willing to admit it and to back off. Because I may have such profound vasoconstriction that I'm shunting from artery to vein without utilizing oxygen. Okay? All right, really, really, really important. So your target is I want to get SpO2 to about 70% in the absence of metabolic acidosis. Getting SpO2 to 70% is not good enough if you still have metabolic acidosis. So let's just go back to Mr. CJ. We're going to see him again, but I'm making it up right now. Mr. CJ has a central line and his SpO2 is 72%. His blood pressure is 70/40. So I tripled his norepinephrine, which was at 4, and he's now at 12. And his next SpO2, I'm sorry, so his first SpO2 was 55%, which is what you expected. It should be down because he's acidotic. I add the vasopressor, and now his SpO2 is 70%. Are you happy?
No.
You don't know if you're happy. Because you have to actually look at indicators of metabolic. Okay, so 2 scenarios. I've resuscitated you to 70%, and your base, which was -9, is now -5. Are you happy? Are you going in the right direction?
Yes.
Happier.
Yes.
But what if your base was -9 and now it's -14? Are you better?
No.
Are you worse?
Yes. Yes.
Okay, good. Excellent, because this is the cornerstone of shock. Titrate vasopressors to your blood pressure, but don't overburden the heart and don't limit capillary blood flow. You know you overburden the heart because the volume now stays in the veins. You know that you've affected capillary blood flow because your acidosis has gotten worse. And when people just hang their hat on these little measures, we are killing patients. I'm sorry, I don't mean to be so blunt, but it's just the truth. And maybe I've had a lot of coffee today. Okay, my friends. So now let's take another look at a visual. SaO2 90 to 100%, SCVO2 65 to 85%, SVO2 60 to 80%. I'm looking at what went out, SaO2, to what returned. And just the number just depends on where I measured it. And in general, we're just going to use the general rule of thumb, 60 to 80%. Anything less than 60%, by the way, means my patient's at risk, but he is using oxygen. So at the moment I see an SVO2 of 45%, 30%, 28%, I'm like, thank God he's using oxygen, but I better resuscitate him quickly. Because he is in the organ infarctive region. Anything less than 60% SpO2 puts you at risk for organ infarction, multi-organ infarction. So everything I'm going to do now is about resuscitating. I want to get your SpO2 up. And I want to get your acidosis down. Good? Everybody good? That's a really important concept when we're talking about shock. It's really, really meaningful. Okay, so I want to just make sure you appreciate. Shift, because there will be a question on this. And the term is oxyhemoglobin dissociation. Oxyhemoglobin dissociation. What makes your hemoglobin release oxygen? Shift to the right means you released oxygen from hemoglobin so it could be dissolved in the blood and used by the cell. Shift to the right is always happy because it means your patient can use it. It also means your patient's at risk. Shift to the right, you're at risk. Shift to the right, anything less than 60%, shift to the right, patient's at risk. Cells need it, and cells can get it. That's it. So you can memorize all sorts of things. Oh, it's this temperature, it's 2,3 dpg, it's this, it's this, it's this. Cells need it, and cells can get it. So if I have metabolic acidosis, do I expect to shift to the right? Yes, always. With metabolic acidosis, always expect a shift to the right. Always. Shift to the left. I don't know if I've got that on there, so okay. So shift to the left means hemoglobin is latching on to the oxygen. Shift to the left, latched on. Either cells don't need it, or cells need it, but they can't get it. Okay. If cells don't need it, will you have metabolic acidosis?
No.
Okay, good. Now, again, I'm making this quite simple because I'm making it for the exam. I mean, you always have to have a much bigger process. Shift to the left, cells don't need it, I'm not going to have metabolic acidosis. But shift to the left, cells need it, but they can't get it. Will I have metabolic acidosis?
Yes.
Okay, excellent. That, my friends, right there, if you've got that, you know what? You are going to do so great on shock questions on the exam. And when you apply this to yourself, it's going to actually really improve your style of caring for patients. And I feel like I'm yelling, but I'm recording also for the virtual thing, and I'm not near there because I'm having an interaction with you, which is what I really like, an interaction. Okay, so venous curve, exactly what we've just said. What promotes a shift to the right? Whenever the hemoglobin releases, because cells need it and they can get it. Shift to the left means either the cells don't need it or the cells need it, but they can't get it. And the difference here is the presence of metabolic acidosis. With metabolic acidosis, your first expectation is shift to the right. In the absence of metabolic acidosis, you expect to shift to the left. But if you have a shift to the left with metabolic acidosis, you're really in trouble because you are not releasing oxygen at the cellular level. Okay, is that good? Excellent, excellent. So cells need it, cells can get it. Cells don't need it, or cells can't get it. And the difference here, metabolic acidosis. When cells need it and they can get it, you'll almost always have some level of metabolic acidosis. It might be really minor, but you'll have some level of metabolic acidosis when they need it. Because metabolic acidosis is part of what encourages the hemoglobin to release the oxygen. That's actually why people talk about don't give sodium bicarb. Because sodium bicarb gives a signal to the hemoglobin not to release the oxygen. And the problem is still there, but now you've given a signal in the serum because you've neutralized the pH. You've given a signal to the serum, to the hemoglobin not to release the oxygen, which makes the actual lactic acidosis worse. Makes you feel happy because your pH looks better for a short period of time. But it actually makes the problem worse. That's why people don't like bicarb.
That's why we intubated a patient a few weeks ago who had a normal CO2 and a normal PaO2, but his pH was like 7.
So you intubated him because you wanted to make him blow off CO2. Because remember, with metabolic acidosis, your patient had metabolic acidosis. With metabolic acidosis, hydrogen is up. And hydrogen is binding most effectively to bicarb. Hydrogen plus HCO3 makes H2CO3, which then puts a burden on the lung, and you've got to be able to blow that off. So very good job. Actually, intubating, I mean, I might have tried something else, but that's okay. Intubating that patient so that you can control his breathing, so you can help him blow off CO2 to get his pH up to a more normal level and protect him from a vascular perspective. Fantastic.
And his entire right lung was a tumor. So that's what he was already.
Yes.
So he didn't-
And he couldn't blow off
no, he
CO2.
didn't have the capacity.
So
Okay,
just
that
doing
makes
that with the ventilator was perfect. So they probably put him on a rate of like 25. Give him a minute ventilation, probably around 13 or 14, which then dropped his CO2, brought his pH. And they didn't want to drop to 5 or anything, but dropping his CO2 to maybe 25 or 28, bringing his pH up to about 7.28 or so, which means that we're kind of protecting this vascular tone. Cool, very good. Okay, so acid is up, base and bicarb's low, anion gap is wide. Your expectation in the presence of metabolic acidosis, your expectation, your prayer, your hope, your dream is that SpO2 will be
Low.
down. And you know what? We don't like it when it's down, but thank goodness you're using oxygen. And we have a very narrow window of time where this is going to persist and you're going to actually lose the ability to utilize the oxygen. Now your SpO2 starts to come up, but you are getting worse and worse and worse and worse. Yeah.
When we see that we're using SCVO2,
When we're using the oxygen
we're using
from
it
our
and it
hemoglobin,
goes down. Are we also making ventilator changes, like increasing the FiO2 so that there's more available oxygen or no?
if you're sat there at 88%, manipulating your ventilator as a distraction,
Okay.
it's not gonna, it changes by so little. The thing that changes it the most will be enhancing the stroke volume and if necessary, getting more red blood cells. Changing the SaO2. And a lot of people do it, and it's just a distraction and a delay from doing what's really necessary. So, at the end of the class, which is pretty quickly, 14 minutes, I'm gonna give you a little calculation so that you can actually calculate what changing FiO2 and therefore the SaO2 was actually gonna do to oxygen delivery. Okay, all right. Okay, so remember PVO2, which is from that same central venous sample. So you're always, everybody is always looking at SpO2. But here's the thing, you should also be looking at PVO2. PVO2 is normally 40 to 50 or 45 to 55, but anytime your PVO2, so you've drawn a central blood gas, you send it for an SpO2, you get the SpO2 back and you get the PVO2 back. Anytime your PVO2 is less than 37, it means your patient is using a huge amount of oxygen. And you are not supplying adequate delivery. So patient has to use more, so their SpO2 will be down, their PVO2 will be down, but the PVO2 is actually a better predictor of how sick that patient is. Okay? That's really, really, really profoundly important. All right. So now I'm going to just apply that when we're talking about all things shock, PaO2 80 to 100, PVO2 40 to 50. If it's measured from your central line, PVO2 3650 from the PA catheter, it's okay. No one's going to ask you if you know those normal values. All I want you to remember from your practice is that when you send a central venous gas off, SCVO2, don't just look at the SCVO2, the saturation of oxygen on the hemoglobin. Look at what your patient is using from the dissolved state, and that's PVO2. So you need all those numbers because it really gives you a lot of good information. Our focus a lot of times is just on SCVO2, but you should be looking at other things as well. Okay, acid up, base and bicarb low, gap is wide, SCVO2 is low, and PVO2 is low. Is your patient okay, or is he in shock? Shock, 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 shock. And you need to be looking at all of this when you're resuscitating. Okay. The last but not the least is just remembering that the number one form of carbon dioxide is the one that is produced at the cellular level. And that is measured as PbCO2. Normal PbCO2 is 45 to 55. It's 5 above normal, 40 to 50. It's 5 above the normal arterial CO2. 35 to 45 is arterial, so 40 to 50 is venous. When I produce CO2, actually, no matter how much CO2 I produce, I should be able to eliminate it by breathing. And that's end-tidal CO2. End-tidal CO2 should be 5 less than arterial. So if normal arterial is 35 to 45, normal end-tidal is 30 to 40. Plus 5 is venous, minus 5 is end-tidal. Arterial CO2 is what's left over. From my point of view, the least meaningful. Because I need to see how much CO2 you're producing and how much you're eliminating. If you're producing a lot, that's a big burden for the lung. You've got to blow that CO2 off. If you can't blow that CO2 off, it's going to remain in the arterial bed. And I have to go back and say, is the problem elimination, the problem production, or both? Okay, all right. I'm going to skip that. I'm going to skip this right here. Because they're not going to ask you a question. I think this is really incredibly and profoundly important, but they're not going to ask you about this. This is a really newer indicator. Okay, so acid up. Whoops. Acid is up. Base and bicarb low. pH is down. Gap is wide. SVO2 is down. PVO2 is down. And my PbCO2 is going to tell me about problems with production. So if my PbCO2 is 55, 60, 70, I'm producing a lot of CO2. That's going to be an incredible burden from my lung. If my lung is able to regulate it, then my arterial CO2 will be normal. So if I can't regulate it, I'm going to need intubation. I'm going to need ventilatory management. Okay. All right. So in terms of shock, 6 staples. First compensation, always increase cardiac health. This is the patient. Second compensation, going to take more oxygen from the venous reserve. So the SpO2 is going to go down. Third compensation, anaerobic metabolism increases. When anaerobic metabolism increases, you're going to start to produce more and more and more lactic acid. That's your compensation. Number 1, patient increases his cardiac output. Number 2, he's going to increase the use of oxygen from the hemoglobin. Number 3, he's going to switch to anaerobic metabolism, which means lactic acid levels are going to go up. Okay. Well, we can treat here. We can't treat number 2 or number 3. All we can do is treat number 1. We try to make sure you have a good heart rate and an adequate stroke volume. Good? Cool. Okay. So stroke volume monitoring, SpO2 or SCVO2 monitoring, and indicators of anaerobic metabolism, base bicarb anion gap, and this last one, which I really love, but they're not going to ask you about it. We'll talk about it another time in another class. Okay. So here's what we say. SpO2 down, base is in deficit, gap is wide, pH is down, PVO2 is down. I'm going to increase your stroke volume. I'm going to increase your inotropes. If I have to give you a vasopressor, that is about blood pressure, not about blood flow. And stop thinking that making blood pressure better is improving blood flow. It is not. You've got to improve blood flow, stroke volume, and inotrope. Okay. And you can also help your patient decrease their demand. If they're hot, make them cool. If they're anxious, make them calm. If they're in pain, control their pain. Cool, calm, collected, pain-free, reducing the demand for oxygen. Reduce demand, increase supply. Good? Right, so now let's test it. One thing. Probably. In your stroke volume, it doesn't matter to me how you're gonna monitor stroke volumes. And Mrs. M, 50-year-old female admitted to ED after a motor vehicle collision. So right away, you're gonna say, might be an hemorrhagic shock, might be hemorrhagic hypovolemic shock, and indeed it's true. She's had massive abdominal injury, she's hypotensive, she has a known history of hypertension, so that hi, guys. So sorry, we kind of lost our visual there, but thank you for coming back. And let me go back into my share screen. Okay, and let me get to that kind of final thing there. Sorry. Okay, so just going to take this quick look at a patient here. And this is really about stroke volume and CVP. So we just look at this patient. Right? She goes off to the OR. She has an estimated blood loss of 2,500. She gets 6 units of Paxil. She gets an MTP. She gets everything she's supposed to get, right? Platelets and FFP and calcium, et cetera. She's still hypotensive on admission in the ICU. So this is her first vital signs here. This was in the ED. Okay. Now, of course, now she's intubated because she's gone to the OR. Okay. So now we're looking at our patient hypotensive despite fluid impact cells, right? Heart rate 130, respiratory rate 32. You already know that's a problem. You're already assuming that she's got metabolic acidosis. Let's just say she has a base deficit of -12 and she has an anion gap of 29. Okay, she's intubated on 80% of FiO2 A to P assist control. Blood pressure is still low, although our MAP is 65, CVP is 13, stroke volume 32, cardiac output 4.16. We're going to give her 30 mLs per kg of fluid. Okay, so look what happened to her. So look, she shifted up. See, she shifted up. Does everybody see?
Yes.
First here, now we've shifted up. That green dotted line is where she was, and we've shifted up. Now her heart rate's a little down, her respiratory rate's a little bit down, her blood pressure is up a bit. CVP is pretty much the same. Stroke volume has gone up. Cardiac output has gone up. And now I'm adding in her base deficit here, which is now -7, and her lactic acid level is 5.2. Are you happy?
Yes.
Is she improving?
She's improving.
Are you happy? Are you satisfied that you've gotten to the end?
No.
No, okay, you're happy that she's improving. So you're gonna give her a little bit more thrust. You're gonna give her some dobutamine, okay? Base is still in deficit, no ketosis, no AKI, no hyperchloremia. So that means it is lactic acidosis, and her lactic acid is 3.1. Her base deficit is -4. You've given her an inotrope, and look what happened. She's only at 3.75 of dobutamine. Her cardiac output is now 7.25, and her stroke volume is 58. Are you happy?
Yes.
Her CVP went up to 20. Why did her CVP go up? Which means that the ventricle is stiffer or less stiff. That's why the CVP went up. Also, her heart rate went up. When the heart rate goes up, less time to relax, less time to fill. I've added an inotrope, less time to relax. So CVP went up because of that. Okay, good. All right, so now she drops her pressure. And the decision is to put her on norepinephrine. And we titrate up really quickly because her blood pressure is 60/32. Heart rate is up 140, respiratory rate's 28, blood pressure 60/32, CVP is 23. It went up because the heart rate went up. Her stroke volume now is 23. Wow, it's gone down. Her cardiac output has gone down. She's on norepinephrine. Her base deficit is worse, her lactic acid is worse. And look what happened to her in this relationship. Here she is now.
Oh,
She better or worse?
worse.
Significantly worse. You're trying to resuscitate her blood pressure, but you're not looking at what happened to her heart. So always make it meaningful. Whoops. Okay. So remember, shock. Add in your preload for cardiogenic shock. CVP will be up, wedge will be up, PAD will be up. Hypovolemic shock, typically CVP, PAD, and wedge will be down. That's what says you don't have volume in your vein. You don't have volume in your artery. You're hypotensive, you're not making urine, but is volume in the vein or is volume in the artery? If volume's in the vein, you're going to consider probably diuretic and inotropic. When you don't have volume in your vein and none in your artery, you need volume. I mean, that's pretty straightforward, right?
Yeah.
Pretty straightforward. And now we're going to add in sepsis, depending on where you are with sepsis. Is it early or is it late? Right? Early. Stroke volume's up, cardiac output's up, heart rate's up, blood pressure's down, calculated SDR is down. Late. Stroke volume down, cardiac output down, heart rate up, blood pressure down, SPR is up. Just like cardiogenic shock. Because in sepsis, you die from cardiogenic shock. So I want to bring us all back together here. And just to remind you, the major methodology in evaluating shock is about the presence or absence of metabolic acidosis and tissue hypoperfusion. You're going to remind yourself that when that occurs, your first question is, do you have volume, yes or no? And where is it? The volume is in the veins and not in the arteries. Vasopressor can help make your arteries tight, but that's not going to enhance the volume mobilization to the arteries. You're gonna have to consider. Cool. Always start with volume. As long as stroke volume is increasing 10%, even if the CVP is going up, as long as stroke volume is increasing 10%, I'm going to give you volume. But if it's not, then move on. Okay. How about that? So fantastic. Okay, it's 10:04. We're going to end our session for today. Do any of you have a question? Not everybody came back after we had a drop, but do you have any questions, my friends who are on here? Feel free to ask. No questions?
I have a question.
Okay.
In the clinical setting, this is Henry. How you doing, Ms.
Fine,
Barber?
thank you, Henry. Hope you're doing all right too.
Yeah, I am. Thank you. I was just wondering, if a lot of times providers still order sodium bicarb. What should a nurse's response be then? I mean,
What do you mean? They're ordering for you to give bicarb? Is
right,
that what you're saying? To administer bicarb? Okay,
Right.
and what's their purpose?
well, of course, they generally would not let us know. They usually see the orders in there. So what should we be doing? Does it depend on what exactly is going on, or is it generally I mean, I'm talking about in the setting of respiratory distress or metabolic acidosis, patients going down and or just recently coding or things like that. Should you
I understand your question. Thank you though for enumerating it.
right? So does it depend?
They never give serum bicarb for respiratory distress. Because you're gonna make the distress worse unless you're controlling breathing. Because when you give bicarb, it will ultimately dissociate into what? Bicarb, marrying the hydrogen makes carbonic acid, H2CO3, presented to the lung, it dissociates into CO2. So do you have to be able to breathe that off? Yes. Okay. So first and foremost, if I'm going to give you bicarb, I want to be able to control the process of blowing off CO2. So I'm going to adjust your respiratory rate and your minute ventilation on the ventilator to help you blow off CO2. But it is really important to understand what is the purpose of bicarb. Purpose of bicarb. Okay. Number one, the only truly bicarb responsive state is AKI. But I can give you bicarb to actually see if you have vascular tonal loss because of metabolic acidosis. I give you an amp of bicarb, your blood pressure comes up. I say, oh, it's because of your metabolic acidosis that you're hypotensive. If nothing else that I can do is going to help you, I'm going to consider bicarb. I might consider a bicarb drip. So the time that I would consider bicarb, number one, I cannot resuscitate your blood pressure and you have metabolic acidosis. Number two, you've got to be able to blow off CO2. And I need to be able to help you do that because the burden of CO2 may be too much for you to bear. So I'm not in love with giving bicarb, but sometimes there's no option. The issue is we have to have some discussion. Are we trying to discover if the patient has vascular tonal loss because of metabolic acidosis? And if so, yippee, I'm going to give bicarb, see what happens, let you know the blood pressure came up when I gave it. Okay. And nothing else that I'm doing works. I'll put you on a bicarb drip. But I've got to be sure I'm blowing off CO2 because when I give you bicarb, I give you a secondary burden. Also, when I give you bicarb, I'm making your pH better, but I'm not really making the cellular process of oxygen utilization better. So that is really a problem. And that's something that we have to consider. So bicarb will not neutralize lactic acid. It's going to neutralize my base. It's going to neutralize my pH. But if I'm giving bicarb, I must be following lactic acid levels. If lactic acid levels, when I'm giving bicarb, went from 4 to 9, I'm going to stop giving bicarb. It's just not simple as just do this. You have to appreciate that bicarb will neutralize the pH, bicarb will neutralize the base deficit, but it may make lactic acidosis worse. And it could make respiratory distress worse because I'm giving the patient now a burden of CO2 to blow off. That answer?
Right. Yeah, that it does. Thank you so much.
So what you do at the bedside is you evaluate your patient after you give bicarb and not just say, oh, look, the pH went up, yay. Because that's probably the natural inclination is I gave bicarb and the pH went up. Did the blood pressure go up? Did the lactic acid get worse? Those are the things. Blood pressure up, lactic acid better or worse. Lactic acid got worse, bicarbs harm the patient.
Right.
Because when I give bicarb, what happens to my oxyhemoglobin dissociation? Shift to the right or shift to the left? Shift to the left because I've turned off the metabolic acidosis signal to release the oxygen. So my SVO2 has come up, but my acidosis has gotten worse. But I can't use now base or bicarb because I'm giving you bicarb. I can only use your lactic acid level. So if lactic acid levels get worse when you get bicarb, that's the wrong solution. Okay?
Got it.
All righty. Very good.
All right. Thank you.
You're welcome. Any other questions? So do we feel we need another day next week?
I would say, yeah.
Yes?
I'll take it. I like as much.
All right. So next week will be our last day of class. We'll be in this room, 8 to 10. We're going to kind of bring everything together. We'll go over some questions and answers, and I'm going to answer to the best of my ability any questions that you might have or things that feel confusing. And that will be our last day of class. Thank you very, very much for coming today. I'm going to stop my recording. I think I already did stop my recording, so that's okay. Oh, no, there we go.